think this is the golden era.
Yeah, I called him the other day to talk about I think there's a small call schedule on
Yeah, I'm not on it, but I know.
So we're trying to figure out at the hospital.
I think
Because the hospital is starting to do.
I was like, it's so crazy. But we can't see the screen, right?
I don't know. I believe because.
Are you staying for the? Okay. I realized that was there.
It's going to be like you and David. So, the more the merrier.
Good. I'm Jim Hunt. That was a good meeting.
So we're collaborating with our provider to take on this grant.
And then they'll prescribe all these and then take on. Yeah. It's not even.
Yeah, up there.
What's happening? Good to see you. Good to see you.
She's always talking about
Yeah. That's pretty good. Originally, I thought it was just going to be like you and, you know. Yeah, so did I. It's fine. Okay. Here, Roberta. Good? Very good.
We're going to get started here. Julie, I feel like you're so far away. Hi.
But you can hear me.
Well, good afternoon, everyone. Thank you so much for being here for this meeting of the Health Policy Commission Advisory Council. I'm David Seltz, the Executive Director, joined, as always, by my Deputy Executive Director, Colleen Elstemeyer. Happy summer, everyone. I hope everyone had a wonderful 4th. I certainly did. And really looking forward to a great conversation today. But before we get started, as always, we're going to do our round robins of introductions and trying to use the microphones. I see Rich has already got the green light going, so I'm just going to start over here.
All right. I'm Rich Buckley from AstraZeneca.
Roberta Herman from the Group Insurance Commission.
Marissa Woltman from the Health Connector.
Hi, I'm Mike Caljo from Blue Cross Blue Shield.
Chris Hager, University of Massachusetts Medical School, Commonwealth Medicine.
Amy Rosenthal with Healthcare for All.
Gary Abraham sitting in for Tara Gregorio from Mass Senior Care Association.
Ron Dunlap, Massachusetts Medical Society, cardiologist.
Bonnie Gilbert, Greater Boston Interfaith Organization.
And Julie Pinkham, Mass Nurses Association.
Carlene Pavlos, the Massachusetts Public Health Association.
Monica Soni from Mass Health.
Emily Stewart from Casa Esperanza, Inc.
Cheryl Pascucci from Bay State Franklin in Franklin County.
Laura Pellegrini from the Massachusetts Association of Health Plans.
John Hurst, Retailers Association of Massachusetts.
Chris Carlozzi, NFIB.
Cheryl Clark, Health Equity Researcher at Brigham and Women's Hospital.
Kathy Keogh, Atrius Health, sitting in for Marcy Sindel.
Caitlin McColgan, Massachusetts League of Community Health Centers, sitting in for Jim Hunt.
Steve Walsh, Mass Health and Hospital Association.
Great, thank you everyone, and great turnout today, great group, so this is really excellent. So for today's agenda, really wanted to have some time for some discussion on two big policy priorities for the HPC for the coming year, and really hope to get your feedback and input on both of these projects. So the first, for the first part of the meeting, we're going to be talking about our work in trying to reduce the tremendous administrative complexity in our healthcare system that is creating tremendous burden on our providers and health plans, and ultimately impacting patient care. This is a project that was really started through you and through the cost trends hearings, where every single year we begin to receive testimony really highlighting the issue of all of the administrative work that goes into our United States healthcare system and Massachusetts healthcare system, and that if we could find a better way to streamline some of these processes, or to have better alignment of some of these processes, that could provide a real relief in terms of freeing up resources that could be dedicated to the types of initiatives that we really want to focus on. So we'll spend probably the first half talking about that topic. And then the second half is an issue that is also a policy priority, very different one, around addressing social determinants of health and thinking about the connection of the medical system with communities and community health organizations, and a new initiative that we are developing with the Department of Public Health and the Attorney General's Office, where the three of our agencies together are working on an initiative where we would help to support communities that really want to tackle upstream interventions to improve the health of their communities and for their patients. So still kind of in development phase is what that exactly is, and so we'll talk a little bit about where we've come so far, but again, really want to get your feedback on how best to design and think about a program like that. So those are the two big things, but a couple of quick hits here at the beginning. First of all, just want to remind everyone that cost trends hearings are coming. So the cost trends hearings will be held October 22nd and 23rd this year. This is our 7th time holding these cost trends hearings. And we are open to suggestions from anyone in this room around some external speakers. We're still nailing down exactly who we'll have as some expert presenters. We're still nailing down exactly what themes that we hope to highlight, and the final panelists. I will note for those of you who are organizations that typically have to respond to our pre-file testimony, our written testimony requests prior to the cost trends hearings, those will be distributed before the end of the month, and those are really important for us to be able to have an information base for the cost trends hearings. But given that we're still in development in this cost trends hearings, happy to either now or whenever, if people have certain themes or ideas or topics, or even for those of you who have been to the cost trends hearings and have some ideas to shake things up or do something a little bit different this year. It is our 7th year doing this, and I think we always want to try to keep things fresh in terms of maximizing the engagement and the impact of those really unique opportunities. So happy to kind of get ideas and source ideas from you at any point about what we should really focus on this year. The next thing I just wanted to mention really quickly is Quality Measurement Alignment Task Force has an open procurement right now for new members of this Quality Alignment Task Force. This is a task force that was organized by the Executive Office of Health and Human Services and we, as well as CHIA, have been supporting it in terms of coming up with an aligned quality measure set for use in risk-based contracts. This quality task force has been meeting for probably 2 years and has made a lot of significant progress. The focus is shifting a little bit more now towards quality measurement development and what is the future that we want to prioritize in terms of creating new quality measures and what those may look like. But since it was, I think, the 2-year mark, wanted to reopen the task force. So if you or you know someone who may be interested in participating on that task force, there is all the information here around how to apply. Great. So I'm actually going to skip through all of this next section. These are a couple of our most recent reports and publications that have come out and that may be of interest to you. The first is on an analysis of pharmacy benefit managers. The second is a report on the availability of providers who can treat patients with co-occurring mental health and substance use disorder. And then the third is a new chart pack that we did on opioid-related acute care hospital utilization. All of these publications, except for the co-occurring disorder report, are in your folders. We put in the slides here some of the main findings. If we have time and want to go back and look through those, we can, but I really wanted to skip to the conversation on and discussion on administrative complexity. So if you're in your slides, we're moving all the way to slide 26. I'm joined here with Kara Vidal, who is the senior manager who has been spearheading this project. I don't think I need to set it up too much in terms of why this is an issue that we're looking at. But certainly we know that this is one of the differentiators between the United States and other developed countries when it comes to healthcare is the amount of money that we spend on the administration of healthcare. And what we've continuously heard from through our cost trends hearings and from your testimony is that it feels like it's getting worse and that this is becoming an ever increasing burden. So what we did to try to tackle this project is first to try to understand what do we mean when we talk about administrative complexity? What is that? What are we actually talking about? And certainly, it's a buzzword. It's a word that we administrative waste, administrative burden. But what exactly are we talking about? So we tried to think about on this slide on 27 some of the different types of things that we've heard about again and again: prior authorization, credentialing, role of EHRs, quality measurement, and start to think about these in terms of some different buckets. And we're not proposing to have the perfect taxonomy for all of these different types of categories. But if we were going to try to prioritize where we could do action, let's try to at least think about how we can bucket these things into things that we could then try to tackle. This was also a recommendation in our cost trends report that we begin to identify areas of administrative complexity that, again, don't provide value. And I think it's an important point here because we do know that there are administrative processes that do provide value, whether that's in ensuring the quality of the caregivers, whether that's ensuring against fraud or misuse of services, whether that's ensuring safety of institutions. There are a lot of administrative processes that healthcare providers and plans have that have a real purpose and an intent behind them. However, even with those that do provide value, they may be misaligned in terms of every health plan may be having a different way that they do that. Every healthcare provider may be having a different way that they do that. There may be processes where truly the technology is not working the way it should be, that we're still doing things on paper that could potentially be done much more quickly and efficiently through an electronic system. So thinking about areas of where the costs really outweigh the benefits and trying to really focus in on that. So with that, I'm going to turn it over to Kara to just talk a little bit about our process for bucketing these things, selecting some of those focus areas, the survey that we went out to all of you with to get some more information on, and then really want to, at that point, open it up to a discussion about what areas are our highest priorities, where can we take this project next, and really use this as an opportunity to advise us. I'd also just want to take a moment to recognize that the Healthcare Financing Chair, Cindy Friedman, is here with us today. So thank you so much for joining us. And I know this is an area that you are also interested in for this coming session. So with that, I'm going to turn it over to Kara to walk through the next couple of slides.
Thank you, David. So, as David said, the first task before us was really to figure out what large categories of administrative complexity we wanted to focus in on and ask for you all to prioritize for us. Had we not had to do that task, we probably could have put that survey out in February because it was a very large task. And as we started to dig in, we found that there was just an incredible amount of information in each one of these categories about where the complexity came from, what's preventing efforts from simplifying it, what is the cost impact on payers or providers or patients, and what efforts are being implemented maybe in private organizations or in different states or even in other countries to work on that. So coming up with that list was certainly a challenge. It was drawn, I would say, mostly from the literature. There's obviously quite extensive literature on administrative complexity. It's been decades worth of research at this point. So we tried to draw on the topics that are listed most frequently in research as being the most costly, the most time intensive. We also drew on conversations from many of the organizations around the table and many organizations who are not around the table as well. And our goal was really to focus on areas that are truly administrative. I think our initial brainstorming list had many areas that are complex, but not necessarily administratively complex. So we tried to really keep the list to administrative tasks specifically. And then after coming up with the list, which is actually a few slides from here, we'll show that before we show the results of the survey, we also wanted to come up with a few principles for how we might prioritize within that list. So those are the 4 principles on the slide before you today. First, because the HPC's orientation is towards reducing healthcare costs, we felt that we should choose an area where reducing complexity would result in lower healthcare costs without jeopardizing quality or access. The second is that it has to be an area that's a high priority for our stakeholders, otherwise really, why would we be addressing it? The third is that we wanted to focus on issues that could be improved at the state level, maybe not completely resolved or aligned across all payers, but that we can make a meaningful progress as a Commonwealth. And the fourth is that we didn't want to duplicate any existing efforts. We want to complement any work that's being done on a particular area. Obviously, the assessment of how each priority area lines up with these 4 factors is still in progress, and our focus so far has been on figuring out stakeholder priorities, which is where the survey came in. So we've met with several individuals and organizations over the last weeks and months from all different sectors, and we heard about many efforts that are already underway to address administrative complexity, some happening within individual organizations, others happening in collaboration across not only organizations in one sector, but across sectors as well. And we heard about some great successes, things where work is progressing and things are improving, and other areas where progress has been a little bit slower. So in order to more formalize the feedback that we were receiving through these meetings, we distributed to you all the Reducing Administrative Complexity Advisory Council survey. So you were asked to rank whether each of the 12 priority areas was a high, medium, yes?
Can I ask, I noticed, I think you got 12 surveys back. How many were sent out?
I think we got 15 back, and they were 30 sent out.
Oh, 15, okay.
Yep.
So about half.
Yes. So respondents were asked to rate each of the 12 areas as either high, medium, or low priority, and limiting your high priority rankings to 3, which seemed to be very difficult for some of you based on the free text comments that we got, so thank you very much for that restraint. We then evaluated priority areas in 2 different ways. The first was by assigning point values to each of the areas where a high priority rating was given 2 points, a medium 1 point, low 0 points, and then we separately counted the total number of high ratings that an area received. So, just to heighten the suspense a little bit, although I think the results are in everyone's slides, here are the 12 areas that were in the survey. And here are... Oh, sure, we can absolutely walk through each of these areas. Yeah, so even a little bit more suspense. Great. So many of these, I would say probably 6 or 7 of these areas come up very frequently in the literature. They are known to be very costly, both for providers and for payers, and they many of them have been made electronic over the past years or are in the process of being made electronic. So for example, billing and claims processing, eligibility and benefit verification, referral management, and I think we may have collapsed a few of these, maybe coding, clinical documentation and coding. These are areas that are have to be done repeatedly, often many times for a single patient, and there is work in many of these areas to take them from being a manual transaction to being an electronic transaction. There are other areas here that are not necessarily transaction-oriented in the same way, so efforts to make them electronic are not necessarily they're not necessarily similar to the first set of categories. So for example, we've got clinician licensure, we have quality measurement and reporting, variations in benefit design, variations in payer-provider contract terms as well. And then we have categories that are very large and even more complex than the average area of administrative complexity, like EHR interoperability, where you can come at from several different angles. We do have definitions of each of these categories that I'm happy to walk through as well, but we're happy to answer. I don't think we did a ton of grouping ultimately of these categories, but there is a little bit there. So regardless of which method you use to rate categories, the 3 categories with the solid outline, prior authorization, provider credentialing, and variations in benefit design, came out as the highest priority areas. When you look by total points, we would add the 3 additional categories that have the dotted outline. So billing and claims processing, EHR interoperability, and eligibility and benefit verification. Based on the comments that we got, I think eligibility and benefit verification and variations in benefit design, there was a lot of overlap and interest. Entities tended to rate both of those as high priorities, or in the comments indicate to us that they felt that those were similar. So I think we can sort of group those together in terms of priority areas. But here are the actual categories by points. You can see that there was quite a race for first and second place when you look by total points. So variations in benefit design and prior auth tied for first with 19 points each, and then the other 4 categories with 17 points each. And I think it's important to note that each of these priority areas were identified by multiple types of organizations. We didn't necessarily see organizations lining up where all providers felt one way, all payers felt another way. There was overlap and interest in each of these areas across sectors. So I think now really our goal is to hear from you. I think there are a number of areas we'd love feedback on, both in terms of these topics themselves, what challenges might we face in addressing them, Are there successful models that you're aware of that we should be looking to? How should we engage with you and your organization on addressing these areas? I think we'd also be interested in any feedback on the markers of potential markers of complexity without value. That was on one of the previous slides, or the HPC's proposed principles for selecting areas for intervention. I think all of that's on the table for discussion.
So I would just, thank you, Kara, that was great. And add, we started with a survey of the advisory council. We do expect to expand the same survey to a larger group of both providers and health plans through our pre-file testimony before the cost trends hearing. So this was, it's a small end. This was only 15 responses. I think we hope to get a few more responses. And if there are others in this advisory council who did not submit the survey by that time, but are still interested in doing that, we will accept that as we continue this work. So this isn't the only survey work that we're going to do to try to figure out these priorities. But I guess I just, returning to the ones that were kind of listed, just to kind of kick off the conversation. I mean, does this list and these feel like the right list? And is there anyone surprised that something either didn't get on the, rank higher, or surprised that something did rank as highly as it did? And maybe just even you can say, yep, this sounds good. Mike?
So David, thank you, and Kara, for your great work so far already on this. I feel like this is a huge priority for us as a whole host of stakeholders, and getting some real traction around these issues will be really important. We have separately talked to you a little bit about some of the work already ongoing that we could build off of, so I won't go through that. But it includes work with MHA, Mass Medical, MAP, sort of the stakeholder groups that we could broaden to even a greater group around some of the administrative complexity issues like prior authorization. I think if we turn to the slide 34 again, my sense is on the right-hand column, from our perspective, prior auth and provider credentialing are certainly issues that we could tackle with even more increased intensity, and there would be great value to the system at large. If I look at variations in benefit design, I worry a little bit about our ability to effectuate change on that issue, given ACA requirements and the variety of different benefit designs that go really in a really different direction based on whether the insurance member is private insurance or public insurance, federal or state. And so I think you're hearing probably a profound interest in dealing with that issue because of all the issues that those designs make to the front end of trying to get services. And I certainly think there would be a good service provided by cataloging and understanding the level of complexity on those issues. As going back to your questions for discussion section, your question one is, can the states sort of occupy the field here or effectuate change? That's the one where I'm a little more concerned about in the end whether we can get there. The other two, prior auth, we have to get to even more success on that issue. I know Chair Friedman, it's a big issue for you, and we look forward to working with you on that as well. And provider credentialing would hold a lot of value for us as a collective group, including the concept of proxy credentialing, which we would strongly support legislative changes to accomplish. So I think this is a really good list. I just wanted to note some caution with regard to the first one, not in intent, but in the progress of success.
Can I ask a follow-up question on and I do want to talk about each of these different topics, but in the variations in benefit design, I seem to recall that there was actually a study that was done maybe after 2006 that cataloged the very different plan designs. I think there were hundreds of different kind of tweaks on the plan designs. What is driving that from a Blue Cross perspective? Is this your employer members demanding customization? Is it the consultants and brokers that they work with demanding customization? Are you offering that customization? What is driving that level of variation?
It's a really good question, and we just went through a process of change where 2 years ago we had 72 different product designs, and we've streamlined those down to 40. And in doing so, we asked those very questions. What was driving the change? What was of concern to our members, to accounts? What was happening? And I think part of it is that, first of all, attention to the issue sometimes lags, right? It's always easier to create a new product and not fold out the old product over time. And as you're crafting a new product design or streamlining an old one, we have a responsibility to migrate members to a similarly situated product. So there are precise DOI regulations on issue, including filings that are made with them to ensure member access, network access, et cetera. But in the end, there were three major issues that drive the complexity of benefit design. One is the substantial compliance component of ACA actuarial value changes every year. So our benefit designs pursuant to the ACA have to change in keeping with the ACA's requirement under what they call the actuarial value calculator. The design is required under federal law to change every year. So that means our benefits change every year pursuant to that law, which then means we have to change the delineation of the benefits within that construct so that members and accounts are protected from inadvertent cost increases because of the increase in the actuarial value. So the complexity is very much driven through federal law. And that yearly process is required. We don't have any say in that issue. And then we make detailed filings with the connector and the Division of Insurance where we're tested on whether or not our product designs meet the different levels, the different tiers of product designs that we're required to have. The second issue, which is paired with that, is increased interest on the part of both members and businesses, small businesses in particular, to protect against cost increases. And so benefit design changes often are rooted in the goal of trying to otherwise protect against cost increases that occur year over year. So that's kind of the playing field, but I don't want to underestimate the impact of the federal law changes on this issue.
Julia?
Yeah, no, I just wanted to kind of ask you, as you raised, I can't remember what the percentages of self-insured, but certainly the number of self-insured, those plans are simply tailored to the organization. And, while it may say Blue Cross Blue Shield or whoever on it, it is simply you're a third-party administrator to a tailored plan of a self-insured organization.
I can only speak from Blue Cross's experience, but I think it's true, at least for the Massachusetts carriers, that we tend to see the self-insured market mirror the fully insured market in terms of benefit design. It's a benefit-rich environment. I think John has seen this in his look on small businesses as well, in that we're not really seeing a lot of variation based on self-insured, but that can also factor in, and there's really, again, that's federally, that's ERISA that governs that, so there's really nothing the state can do in that regard too. But I wouldn't overestimate that. I do think that the self-insured marketplace tends to adopt and use the vast majority of the mandated benefits. It's not all that the fully insured networks have in Massachusetts.
Well, I'll get to you in a second, but I do want to try to get a different perspective on this one, because there were many organizations, even in this room, who did highly rate this one as something that...
If I could just make one clarification. While it's true, I think in the Massachusetts market that most employers, self-insured employers, will mirror what's going on in the commercial space, theoretically, they can do their own benefit design. And if you're writing this policy out of state, for folks who live in this state, you could have additional benefit design. Right. So I think we need to be mindful, to Julie's point, is right on. Okay.
Okay. Ron?
I'm not sure this mic is working, but one of the issues is the cost shifting that occurs. So when an insurer ends up with a higher cost these days, and the employer doesn't want to pay that higher cost and wants to offer lower cost insurance, the benefit gets either dumbed down or gets a higher copay, which therefore makes it harder for certain populations to get care. And it becomes very complicated for the doctor ordering the test to know, how much is covered and will this patient show up for that test and what is the site of the test. So that's an important part of this.
Get back to this point, though, because I consider our organization, we negotiate contracts, most of the employers are self-insured, and I think it's a highly knowledgeable group about who it is they want to go, where they want to go, what they want to see. And I said the challenge is that it is a cost shift issue. So a lot of the, the tiers of who you get to pick, it seems to be our ever never-ending moving target, right? So, okay, if I know I want X facilities available to me for specialists in oncology, or I would actually say maternal child health and pediatrics is a huge one for us. If that cost goes up, sure enough, next contract negotiations, you'll find it, but it'll be a different tier. And now you're going through the hoops and bells and whistles, so we'll have people coming and saying, we want you to push the issue of changing the tier, and that's true of prescriptions and stuff too. So the two are directly related. If it's cost, then you get a pushback from members about switching up benefit structure.
Yep. John?
I have to apologize because I was one of the bad 15 who did not respond, and now, in retrospect, I will respond. Late, Kara, but in my mind, what I look for in something like this, I just want to make sure that we're not cutting back on the choices and benefits for small businesses and their employees versus the big ERISA exempts. And if part of the attempt here is to rein in the fully insured, which is primarily small businesses and individuals, we may be discriminating against those that happen to work for small businesses. And I really feel like employees of small businesses need more options, more flexibility, and not less, including plenty of plans, plenty of options to do defined contribution and the like. So I understand some of the administrative problems that are through the process, but we also need to make sure that small businesses and employees are really getting the same level of choices and coverage as their larger competitors.
Amy?
Yeah, for Healthcare for All, this was definitely one of the ones that we flagged. I think a lot of it was in that understanding and navigating part. So thinking about our helpline and the 20,000 calls we get every year, we were really looking at this from the consumer's point of view, right? So, obviously we want consumers to have the insurance coverage that they need and have those kind of options, but at the same time also it's like the questions we get around understanding the differences is part of it. So it may not even be as much on all the different choices, but helping people understand what those options are. We were also one of the groups that then made up another high priority under the other, but I do think it relates to this, which we called member eligibility, and we talked about simplifying and addressing the complexity of member application, eligibility, and redetermination. So I know they are different, but it seems like related, and it was enough to warrant 2 of our 3 high votes. So I just thought I would flag that.
No, I think they are related, and as Kara mentioned, the other category that was eligibility, benefit verification, people kind of were confused about there's a connection, obviously, between the 2 of those categories.
Yeah, but just the takeaway, I guess, is we have to think about it from a systems standpoint, but I also don't want to lose sight of thinking about it from the consumer experience standpoint.
Absolutely, and I think with any of these, we want to have a benefit ultimately to the patients here, and to the consumers, and whether that's trouble navigating or whether that's around the fact that prior authorization may delay needed care in some circumstances, that can also, if we can streamline that, could have a real benefit to consumers and patients as well.
So I think people have raised a number of good points about how we got to a lot of variation in benefits and the extent to which we may continue to have variation, but it's not simply about the complexity and navigation, but the absence of consistency in a core benefit cutting across payers that I think is difficult for consumers. And, you know, you could preserve variation and have core benefits that align.
That's well said. Laura?
Thanks very much, and thank you for this project. I will remind everyone, because I'll be remiss if I didn't, that we have the highest healthcare cost in the country, and 90% of that is being driven by provider costs. 10% is around administration. This is an important issue. We don't want to lose sight, though, of the bigger picture. I think what would really do us well is to set up a subcommittee of people who are interested to really do a deep dive to understand around ERISA, the commercial plans, what's required relative to mandates, minimum credible coverage, the ACA prescribes limits on cost sharing, just to educate folks, but also the initiatives that are going on in the state. We work closely with MHA, Mass Medical Society, Blue Cross on the Mass Collaborative, been in existence for years. We have a set of priorities there. NEHAN is a not-for-profit group that I think really emanated from Beth Israel, where they're doing a lot around electronic transactions, whether it's payment, whether it's eligibility, to really educate all of us about what the opportunities are out there, and I'm sure there are many others that you've talked about. As we think about benefit design, I think as Amy was talking about eligibility and redetermination, that's the Mass Health issue. So it's really important that Mass Health be a part of these conversations, and I know that they've tried to streamline eligibility to make it less chaotic as far as the redeterminations. On prior authorization, I think there's really great potential there to really move to an electronic platform around prior authorization, and I will need to double check the law. I thought there was a standard in the law about how quickly plans need to respond around prior auth and to make a determination on that, or else it's deemed approved, but I will double check that. And then on credentialing, that has been, I got a text from somebody in the audience who said we've only been talking about this for 20 years. It is a priority of the providers, and we are standing side by side with them to try to get this streamlined and to get it to work for them so they can get doctors up and running. So thank you for your attention on these issues, and we look forward to working with you.
Yeah. Second highest cost in the country, but
oh,
yeah.
Excuse me. See your good work.
Making progress. All right, let's move off of variation in benefit design and talk about the other two highly ranked ones, prior authorization and provider credentialing, because it seems like there may be an area where there may be some opportunity. So again, interested in hearing from other advisory council members on whether those are worthwhile to go after, and any advice that you would have in terms of how we would actually do that, and who would be the right people to talk to. Are there examples of places where there has been really great progress being made? We are certainly, Laura, have talked to all of the different organizations who are working on these things, and there is, as Kara said, there is progress being made, but I think we also think that there are places where we could have more urgency and momentum in pushing forward some of these ideas. So interested in any feedback or comments on these ones. Kathy, do you want to jump in?
I don't know, is this working?
Yeah.
So I guess I'd like to echo what Mike said about provider credentialing. From a physician perspective, if you're onboarding a new physician who just graduated, or somebody from out of state, it can take, if it's around May, 12 to 16 weeks currently with the Board of Medicine, and I'm not throwing anybody under the bus, but that is really the first step of many, many steps. You have to get a state-controlled substances registration, and to the credit of DPH, they have streamlined and gotten away from the paper-based system, but then you have to go to DEA, and that's only first of many steps. So I do think there is legislation to have nurses have Massachusetts join the Nurse Compact, but there is not legislation currently, except for I think there's something that requires a study for physicians to join what also exists right now, which is a physician compact. I can tell you from firsthand experience, and actually there's model legislation on the physician compact, so you don't have to start from scratch. I can tell you also there are a number of other licensees. We dealt with one of our psychologists and it took 4 months. Actually, I'm sorry, 5 months, and they apparently do not have enough resources because they only have one person who works 1 day a week, who's handling things, and it's really difficult when you're trying to care for your patients if you can't. You want to hire them, you want to start having them see patients to improve access when you're having to go through, people making phone calls, lots of paperwork back and forth that's lost. I mean, it really is something that hopefully, the HPC and others can sort of think about improving on that entire system. I do know that the Board of Registration and Medicine currently does have a consultant in there right now to improve on things. And again, we've been talking about this for a really long time, and hopefully the outcome will be good. But considering joining the Physician Compact may be another solution to improve on that critical mass.
I wasn't aware of that Physician Compact.
Dave, just to really right on to that point, Kathy, we've actually filed a bill with MHA to speed up the Board of Registration in Medicine. We've lost psychiatrists that want to come to Massachusetts from Pennsylvania or Ohio. They can't wait 5 months, and we've lost them. It leads to a lack of coverage on units. It can affect access, whole host of problems. So we just want to move this a little quicker, like 90 days. That's what it says in the bill. We would like the Board of Medicine. So that's filed by Senator Hines, and it's somewhere in the legislative hopper now.
Yep.
Thanks. Just follow up on what David said. We're looking at this through the wrong lens. In terms of provider credentialing, we've been looking at it as an issue to help physician organizations or hospitals to get people credentialed faster. It's a patient access issue. And if we start talking about it as what it is, there'll be far more momentum to have a change happen. With the number of closed panels that there are among our providers across the Commonwealth, people can't get care. So we are not getting people the care that they need and deserve because of a system that is controllable by us. And I understand there's a lot of challenges to credentialing a doc, and you want to make sure if you're looking into the background or other things, nobody wants to have that incident that may occur where somebody credentialed or rushed through somebody who wasn't seeing patients appropriately. But on the flip side of that, there's a whole host of patients that are on waiting lists to get into a closed panel, while there is a doc that has been hired by a physician organization or a hospital that currently can't see patients because their application is on a desk someplace and waiting to be reviewed. And that should simply be unacceptable to any of us that want to represent patients.
Diane?
Thank you. I also wanted to just bring up the issue with prior authorization. I think that's a real significant problem both for providers, hospitals, but also really for patients. Because even a simple thing of getting prescriptions renewed that patients have been on for a long time, suddenly formularies change, prior auths are needed, and then they're left to the complexity of getting the approval, particularly if their providers have a big system. So it really is delaying care. And then obviously from a provider perspective, it's a huge burden for us to make sure we get that, get that approval, or else we don't get paid.
Yeah, in both of these issues, I think you can see a patient impact story, and I think that is, part of what motivates us to try to take some action and highlight, and not to say that the HPC itself will fix these issues, but can we help convene and influence and create the momentum to be able to address it, and that's really part of our goal here. On the provider credentialing, I would also note there is, some organizations, really just can't afford to have someone not see patients for a while, and it feeds into kind of the haves and have-nots in our system and kind of the inequality of resources as well. Ron?
So, a number of years ago, there was a company that provided credentialing that was, I think, accepted by something like 8 or 9 hospitals in Massachusetts. And a number of us working in academic medicine because of our very low salaries, we moonlighted. And so we had a business of 100 physicians from the top hospitals in Boston who covered the emergency rooms and ICUs of community hospitals. So we had to be credentialed sometimes at 6 or 7 hospitals, including our several academic hospitals. And because of that service, it was quite easy to have your credentials done, because once you did it into that service, it moved across borders, so a barrier. So I think that's the kind of thing. It won't help the people onboarding from out of state, but it certainly would help moving people and providing access in new venues for certain providers. In terms of the interstate compact, that provides that if you have your boards in a given specialty, that you could therefore be licensed. I think there's 16 or 17 states that had to sign on in order for it to go through. The upside of it is you get care. The downside of it is that with telemedicine developing, there are issues about whether or not the provider has to have a presence within the state. State boards have taken a position in Massachusetts that they want that, because what happens when you need follow-up after that consult? Because there are very large reputable systems who could therefore become national companies doing telemedicine who've never set foot in Massachusetts. So there are issues that have to be looked at there in terms of that. In terms of the prior auth, I think that I just looked at a study that showed that the average among all physicians was something like 4.5 hours a week, up to 15 to 16 hours. The staff time was something like 11 hours. I can tell you in cardiology that we have to have a full-time person who does just prior auths for procedures, and the number of procedures that are denied is quite small, but that's a salary you have to spend. Nationally, we've looked at trying to make the forms that we use uniform, so that you learn how to use that form and you can move forward. The other thing is to have peer-to-peer review. So I can't have my cardiology procedure reviewed by a psychiatrist, nor could the psychiatrist have their request reviewed by a cardiologist. So I think that in certain cases that's important. But in other times, you're trying to reach somebody on the phone and you go through voicemail and you finally get somebody who's sitting in front of a computer screen who has no concept of medicine but has a list of approved medications. You have to stay there on the line while they find the 3 indications for that, an acid or whatever, and it drives you crazy. So that you actually put these in a pile and try to keep working because you're falling behind. And at some point, at the end of the day, you've got to try to reach these people. But just that interaction, if there was a uniform way of doing this, so that we knew how to fill out the forms and could get it in, the computer could make that decision.
And we have made some progress in uniform forms on prior authorization here, but I think has only been in very small subspecialties. I'm looking at Kara, she probably knows.
There are a few forms that have been done. I don't think they're necessarily the small specialties, but they typically haven't been for like med surg generally. There's many that haven't been covered yet, and to my knowledge, that we haven't yet gotten to the point where it's so uniform that a computer can be making the decision. Standard.
That's the future.
And this is a great conversation. I just want to also, I should have said this at the top, but part of the next steps in this project is taking the reflections of the survey and of this conversation to the board, the HPC's board, at the end of the month, and to have a similar type of conversation with the board. So this conversation today is really intended to help feed into and to be another data point as I take this to the HPC board as well.
Consistent with all of the comments that we've heard about the popular topic of provider credentialing, we see that it doesn't discriminate among types of providers. It's all types of providers in different licensure levels, and query whether it would make sense to Steve's comments about reminding us this is really at the core of it about the access, whether it would make sense to kind of, if a deeper dive, if it hasn't already, included really kind of parsing out which types of providers. I mean, we know we can do better in credentialing all types, but to really be able to better quantify the impact on access to particular types of services may or may not reveal some trends that maybe would help prioritize what to attack first.
That's helpful. And if I'm reflecting on the fact that I think, Laura, you got a text message that said, we've been talking about this for 20 years. Are there, I don't think we want to talk about this for another 20 years, but we're looking and hoping to try to find ways to move this forward, and whether there are ideas that Ron mentioned or others, we're really interested in helping to source that.
Yeah, Dave, I was just going to agree with my colleague Laura about a subcommittee, and if you do that, maybe there needs to be, I would certainly say, and you guys would be a good one, maybe Marty or somebody on one of your commissioners, a behavioral health subcommittee, because there is so much micromanagement and regulation in behavioral health, and such a waste of resources. People have to jump through. They're seen by 3 or 4 different people before they can get admitted to a hospital. They have to get prior approval. Some companies have eliminated prior approval, which can have some benefits, but I also have hospitals that say they want prior approval because at least then they know they're going to get paid, because if you don't have prior approval, you might not get paid. So it's all over the board, and I think that if there is a lot of resources being spent on things that aren't patient care in behavioral health, managed care and so forth, and pre-screening and prior approval. So I would put in a plug for, some kind of subcommittee under Health Policy Commission to look at behavioral health.
Thank you, David. Emily?
I'd like to just say yes. Because, to the earlier point about the amount of time spent on prior auths, working in addictions and behavioral health, we have a full-time person, and we're not getting reimbursed for cardiology. So it's a huge expense, and I think there are unique issues to behavioral health for sure.
That's helpful. Roberta, I don't know if I could call on you for your perspective on some of these issues.
I've been quieter than usual?
Yeah.
Well, I don't know how far back you want me to go. On the benefit design change, I couldn't help sitting here and thinking about how I've never heard from my members that they want fewer choices. Let's just put it that way. So I think there's a lot to be researched and understood in terms of what do we mean there in terms of the complexity, and certainly we could do a lot better. I think whether they want to be or not, members are finding that they have to know more about navigating the healthcare system than they ever did. So it would be important to parse that out. On the provider credentialing, I'm a little bit perplexed because I thought we had a collaborative on provider credentialing. I would agree behavioral health is definitely a different area where I think that it would be really important to do. It would almost be more important to frame it up in the first place as a behavioral health access issue, and this is one component. It's sort of personally the way that I see that issue, but that might be splitting hairs a little. And on prior auth, well, yeah, I think that part of it, for me, means I really need to understand what's underneath that. Nobody wants to be managed, but everybody's very concerned about costs. So certainly in terms of coming up with standard formats or electronic interfaces, that makes a lot of sense. And there may also be a role for developing some consensus about the areas where it's particularly valuable and less so. So that's just top of mind.
That's great, thank you. Or?
So in the spirit of maybe a subcommittee, so I got another text with a very mean red face. So we have a group of folks that are part of the collaborative. Liz Leahy from my shop, Karen Granoff I think is here, Yael Miller and others have been working diligently. It's a requirement in the law that we come up with standard prior authorization forms that can be no more than 2 pages. And so to just correct for everyone, they've done all the forms for behavioral health. They've done all the imaging forms, and they've done all the prescription drug forms, and they continue to do this work. It's very time-consuming. We bring in specialty groups from Mass Medical and MHA, et cetera, to really get input from the experts. So not to take time here, I think it just kind of lends itself to why we maybe should do a subgroup of interested parties to really get a lay of the land and landscape of what's going on relative to administrative simplification.
And did not want to minimize or diminish the work that the collaborative has done on this, and there has been progress. I think the question is, are there ways that we could accelerate that progress or take it in a different direction? And in some cases, having standard forms for prior authorization is a really good, important step, but I think there's a broader conversation about, do we actually need prior authorization for all of these different types of services, and are there places where provider organizations could be given the responsibility and trust to manage care of their patients if they're under a risk budget, or that they have demonstrated the clinical expertise and capacity to be able to say a prior authorization isn't necessary. So I do think there are other elements to this more than just a uniform form that are worth exploring.
I haven't run this by my board, so I'll say it anyways. And Roberta maybe has some thought, but I think if a provider group is taking full risk we should think about that
Yeah.
in relieving them of those obligations, because they'll be managing the care themselves.
Steve, did you want to jump in?
Follow up on Laura. I think that this is really an answer to question 3, which was collaborate with other organizations. I don't think what you're saying is inconsistent with what the collaborative is doing. I would just caution to say that when you really get into it, it's not going to be done in 90 minutes today. Just to try to keep in mind to make sure that your approach is complementary.
Absolutely.
Or if you're trying to push the industry to go further, that's fine. We can always be pushed harder, but to make sure that you're working with the group that is already working and done yeoman's effort to get us to this point. And I think you've already made that commitment, so I don't think it's a real concern.
Thank you.
Just one additional comment from a health center perspective. I think we would totally agree with credentialing as a huge issue. Love to participate in that effort. I would be remiss if I didn't note on the billing and claims processing, which was tied on total points. I noticed on the left-hand side, even though not on the total highest. That's the overwhelming issue I would say that I hear from our members. I work with our biller groups, our CFOs, and just the complexity of some of our interactions of our safety net coverage rubric, which is wonderful in Massachusetts, but the way that those coverage types interact and the systems we have in place means that we have a lot of unique billing and patient accounts manager roles that I think many other providers do not have. And when I talk to folks, usually we have an outflow of those kind of staff from health centers to other provider types. But on the rare occasion I talk to someone who's incoming, they usually say, this is the most complex environment I've ever worked in. I don't understand how you get claims paid. And I'm like, well, welcome to health centers. We have a work group for that. So, but I want to note that. I think our members would say I fell down if I didn't note that.
And I do want to, there's 4, 5, and 6 on this list here too. And as you noted, in terms of total points, that's tied with the third one. And so definitely there was a lot of people who had indicated that as at least a 1. So it was probably that, these are the number 1 second choices. And so, certainly want to hear thoughts and feedback on any of those as well. I was candidly a little surprised that the EHR issue didn't score a little bit higher. And billing and claims processing is certainly one that we hear about all the time. Julie, I think you had raised your hand really quick.
Just a question on the issue of prior authorization. Is the push of not wanting prior authorization coming more from the patient consumer side or more for others? Because I just go back to the fact that from just a narrow lens, if we have a large system is self-insured and the bulk of its own employees are covered by their own employer-provider organization, which is their own institutions, their own providers, everything, and they can create their own benefit structure, and their benefit structure requires prior authorization. So I'm like, who's moving the issue, right? Is it, so I guess sometimes when we look at it, I'm like, well, who are you driving the bus for? So, because I don't think it's, if they could already change it, in their own organizations, they haven't, so.
I think that's a good point in terms of the levers that we have to affect change. Certainly if provider organizations are self-insured and they may have their own role in saying, how can we help move the market or change things a little bit? And I think it's a good point. Bonnie?
I was very glad to hear the billing piece brought up, because that was, I know, a high priority for us as well, because it does go directly to the patient issues as well. And we hear about it all the time, the difficulty, especially around mental health, behavioral health services, the denials, the trying to get payback for providers who don't accept insurance. So then it really is the patient dealing directly with the insurance companies. And so I think that's a major issue. And I did want to, before, second the issue about prior authorization, especially when it comes to mental health, behavioral health. I think that that's another place, again, where it directly impacts the patient's ability to get services.
Emily, and then I'll jump to you, Ron.
I want to agree for sure about the billing and claims processing being a huge problem for us. We're a relatively small shop, and it's very burdensome. In particular, though, I think it's tied very much to the benefit verification piece. I think one of the biggest issues that we have is people, I know that we were supposed to, in this redesign, not experience the same level of churn, and what I can say is for sure, people's benefit assignments change all the time. I don't see that it has really stabilized as much as perhaps we had hoped. Certainly in the behavioral health sector, I feel like people are constantly coming in with new benefit assignments, losing coverage, regaining coverage. We spend a ton of time helping people get coverage or, renew coverage, things like that. And so, yeah, I mean, it's very difficult to get paid when you know who's paying you, if you don't know who's supposed to be paying you. And I think with regard to the variation in benefit design, I would just say that my experience has been that, at least with my patient population, they would love way less variation in benefit design. I don't know if that's, specific to the people that we serve, but I think they are overwhelmed with too many different plans and a lack of clarity, again, about going back to Donna's point about what is that core set of coverage that they can count on no matter what plan they're on. But they're getting tossed around a lot, and it's hard to get paid. But most importantly, it's hard to get care.
Emily, are you talking about Medicaid largely? Yes.
I'd like to just comment on the whole variation piece as well. In terms of variation of plans, what you're really talking about is patients having to choose what they can afford to give up. That's really what the variation of plans is going to. And so that kind of addresses both sides of the issue. If the plans covered what the patient expected and hoped it would cover based on what they're paying out of pocket, there wouldn't be a need for this wide variation of plans. It's really being in a sort of Hobson's choice of what are you hoping is not going to happen to your family, and therefore you're willing to take a risk on that being covered at a lower amount. And that's, I think, a big part of this variation of plans, which in that sense is sort of a red herring. It really, because the patients are looking for maximum coverage for the needs of themselves and their family. And I think that goes a lot to what you were saying.
Absolutely.
Ron, did you want to jump in?
Yes. So on prior authorization, so there were some studies that showed that sometimes the actual administrative cost of running the program was about the same as the savings. But psychologically, what happens to you as a provider is that you will avoid things that would take a lot of time. So you will prescribe a different drug, which might not be the best drug. And typically, I mean, I ask my patients what they can afford. So if you really want to be successful, you can't, prescribe a drug that they can't afford because it makes you feel good. They have to go home just with the social determinants. You have to give them a drug that you know that they can afford and take in order to be at least partially successful. So I think that we really have to look at simplifying this. So take the really high cost things. We wanted to have I worked in an electronic medical record for 7 or 8 years as an engineer, and one of the things we wanted to try to do was to have the plans prescribed list of medications be on the computer, so you knew if you wanted an Ann asked for a PPI, that you knew which ones that plan provided for. So I think, but the psychology of basically, there's some reports in this study I read that physicians felt that the drug companies providers were practicing for them. That is a huge problem for doctors in terms of doing this. So I think that the EHR thing involves billing, you're a scribe, and you're a quality manager. So all of those things have contributed to the 20 to 30% loss of productivity for us as physicians and the time we spend with patients. So most people are either doing work after clinic or not seeing as many patients, which basically lowers accessibility. So it's really an interlinked sum total of these things that the EHR is involved in.
Were there, kind of to wrap up this conversation, this has been really helpful and great. Is there anything that we haven't covered, anything that wasn't on the list, any comments anyone would like to advise? Julie?
When you asked for responses, I ended up emailing back because I didn't want to be non-responsive, but most of kind of where you were driving this was far more from the other stakeholders on billing and other things. But I didn't want to not say that there's a huge amount of burden, and people shouldn't consume that, we have this list, that's resolving some of the administrative burden that we're seeing. That's not the case. There's a whole nother layer of administrative burden from a clinician's standpoint in the delivery of healthcare, dealing with electronic health records, who have been designed largely to capture financing and less so to efficiently assist clinicians in doing the work. So it's not really directly here in that way, but I didn't want to sort of assume that somehow it was either less important or not an administrative burden. It's there.
Yeah, I completely agree, Julian. It is a huge issue, and it almost feels like a bigger issue than even this project. And it's something that we're going to be spending some time on, because it's both, as you said, some of these systems are designed really around revenue maximization, not around care coordination or providing clinical support. They contribute to the hardening of networks. And referrals potentially into high-cost specialists and centers, contributes potentially to consolidation and acquisitions, and not even scratching the surface. But your comment is really well taken. Steve, did you want to say something?
Just to follow up on, I think Julie's absolutely right, and I think that if we split the 1 through 6 into 1 through 4 and then 5 and 6, I think there's some really technical and legal problems with 1 through 4 that Mike pointed out, Laura pointed out, that are going to be really hard to get to the bottom of. But 5 and 6 are just technology. There's nothing related to healthcare in there at all. And if you walk into any hospital, Diane's hospital, Chris's hospital, and you just pick 5 people in the waiting room and you ask them where their pain points are, they're in 5 and 6. They're in billing, they're in interoperability, they're in their medical record. And we should, the brains here should be able to figure that out, because that is related to technological advances and not all these other things that Mike is concerned about, and making sure his plan or Laura's plan are meeting the federal requirements and expectations. So it may be that you got those other rankings higher because you're dealing with people that are really understand inside baseball. But if you get that down to the consumer or the patient, they're in 5 and 6, and that should be something we can advance.
One thing is that the light at the end of the tunnel may be artificial intelligence. There are a number of organizations working at trying to take what we used to dictate as a clinical note and extracting the data, because there's a conflict between clicking and pointing, grabbing data, and having quality in your notes. So when you look at my note and Epic for a person with chest pain, they all sound the same. If you show me one of my dictated notes, I can, without a name on it, I can tell you who that person is, because it captures things that are unique to that person. So we really dumb down the system in the name of gathering data. We dumb down the system in terms of quality, so that what I call note load is you have 25 pages on a discharge of a patient, most of it useless, when you could really put on one page that tell you what was wrong. So I think technology and looking at that, I think the ACOS is working on it, IBM's working. I have a half dozen organizations working on that type of technology, which would really get us back to the bedside.
I like that hopeful note. Amy, I'll give you the last word on this.
I was just going to say, we've had 2 high-tech folks who do artificial intelligence actually approach us about our helpline and whether we can be using AI in some ways, and I'm not 100% convinced that would work for us, but it is something that I've had these long conversations about ways and thinking about how it can help. So I would just throw that out there. Literally 2 of them have approached us just recently.
In terms of the processing, is that including denials of claims? Because that is not just a simple processing issue. I mean, all kinds of issues come up under claim denial in the processing, which is a very significant issue for patients.
Yeah, I think that's intended to be under the claims processing, is utilization management and claims denials.
I don't think that is a simple technological, processing. No, that's not. Goes to a lot of other issues.
I just want to add, and thank you again for this conversation. If you have some sense of next steps, you mentioned the cost trends process in terms of eliciting a question and answer on this topic, but do you see work progressing in parallel with that process or sequentially?
I think so. So the next steps are we're going to try to collect a little bit more information, kind of using this structure, just to kind of validate that we're, again, kind of moving in the right direction. This was a very validating conversation here today. Talk to the HPC board at the end of the month, and have their kind of input and feedback on the areas that really feel the most ripe to dive into. And then I think then the work really begins in terms of really rolling up the sleeves, talking, getting into the weeds on these issues and figuring out what's there. I think this whole first part of this has just been kind of like, let's put everything on the table, let's all gather around and then start to say, where are the places where we might be able to make some, progress in the short term, and maybe areas that we want to say, let's make progress in the long term, but that will have a big impact. I don't know what those are sitting here today, but I think it's something that we would want to work on collectively and move forward in a collaborative way. I would say this, I do expect that this will be a topic at the cost trends hearings itself, potentially with a panel discussion at that cost trends hearings again. It's a great venue to kind of raise some of these issues. This was a great conversation as well. So I'm going to take the last 15 minutes of our advisory council meeting really just to quickly introduce you to this new initiative that we've been working on for the greater part of a year with the Department of Public Health. We might not have time interested in your immediate feedback, but also to the extent that you're interested in this topic and want to engage with us offline, we are always, that's part of the purpose of these meetings sometimes is to find out what you're interested in and how you can help us, and as we move this initiative forward. So as I said at the beginning, this really is a reflection of the very strong consensus that addressing the social context of patients is really critical to improving the health and ultimately controlling healthcare costs. This obviously has been a topic that we have been increasingly focused on at the Health Policy Commission over the last couple of years. I think we all, from the HPC staff perspective, remember Dr. Lauren Taylor's presentation at one of our cost trends hearings a few years ago, specifically on this topic, and that really kind of resonated with us. We have, done some research. We had an event. Obviously, many of our investment grant programs have been focused on thinking about whole person interventions. I would say our investment programs to date have been largely more focused on the most downstream health-related social needs, so immediate access to food or transportation, potentially housing. But I think there's a growing sense of how do we kind of move even upstream in thinking about how to address those issues, not just on a patient-by-patient level, but on a community level. And what is the role of the medical system in doing that? And do we want the medical system to be doing that? And I think there's a lot of perspectives that say no, that we don't want to medicalize social services. And yet there is a growing interest and incentive for the medical system to care about these issues in risk-based contracts and through the Mass Health ACO program. And so one of the things we're really interested in trying to think about is can we marry what has been traditionally the healthcare system and the public health system, the community health system, and kind of even beyond that to criminal justice and other areas, education within these communities. So I'm going to ask, I'm joined by Catherine Harrison, who is our interim director for Care Delivery Transformation, just to give you just a sense of this project, where we are today, and then again, look forward to engaging with you further on it.
Great. Hi, good afternoon, everyone. So as David has just alluded to, we know there's a lot of work already going on across multiple sectors, from healthcare to social service to government to community-based organizations that are working on tackling some of these issues. And when we're talking about these issues, it's really, a multiplicity of things. It's everything from, addressing someone's immediate health-related social needs to thinking about the environmental factors that drive health, to thinking really even more upstream than that, to look at our institutions and the social inequities in our society. So there's tons of work to be done in this area, and there's no expectation that any one sector can do it alone. But we do know that the healthcare industry and the healthcare sector can play a role here. But we also know there's great challenge, both within
healthcare systems themselves who are potentially already doing some of these activities across different parts of their organization, whether it's through the community health needs assessment work that they're doing or the community health investment work that's ongoing for the Massachusetts Department of Public Health Determination of Need process, or their own anchor institution investment strategies. So there's that challenge, not to mention the challenges of working across sectors. And we've talked to stakeholders in thinking about how to address some of these things, and they've told us data is another huge challenge, not surprisingly. We're thinking about how do we gather data about people and their needs across different data systems. Sometimes those data can't be shared for a variety of reasons. So there are great challenges here. But there's also an important opportunity to look at these issues in new ways. So we've begun to see a chance really to move forward in this way and to get healthcare systems and community partners working together to address some of these things and to really not necessarily tackle things brand new, but to align some of the work that's already ongoing across things like the Office of the Attorney General and Community Benefits Program, the Determinative Need process, and the Anchor Institution Investing Strategy that I just mentioned. In addition to that, last piece of context, here at the HPC, we've been thinking for some time about offering a technical assistance opportunity for ACOs under the auspices of our ACO certification program. And of course, we have some funding set aside for that and have not yet determined exactly how we would use those funds, largely understanding and recognizing that there's a tremendous amount of resources in the field through the Mass Health DSRIP program right now, and that ACOs have a lot of technical assistance opportunities coming their way in more traditional forms. So all of those pieces put together have led us to identify an opportunity for a new program that we're calling Moving Massachusetts Upstream, or MassUp. And this really is a partnership across a number of state agencies, the AGO, DPH, with the support of EOHHS and other state agencies. And really, we've defined a vision here of better health, lower costs, and reduced health inequities across communities and populations in Massachusetts through effective partnerships between government, healthcare systems, and communities to address the social determinants of health. We intend to engage in both policy alignment activities and to make investments to support collaborations between the healthcare system and community actors such as social service and government and others to more effectively address the upstream causes of poor health and health inequity. So this is sort of a schematic that helps break down a little bit what exactly is this MassUp initiative and what are we trying to do here. So the first kind of piece or prong of this is an investment program, and this is where we would leverage those funds that I just mentioned that the HPC has been thinking about for ACO technical assistance to identify and put out a new HPC competitive grant opportunity for 2 community collaboratives to align activities across these different sectors that address the upstream drivers of health. So it's important to understand when we talk about these investment dollars, we're talking about them going towards supporting a new infrastructure or a new architecture for collaboration in these communities. Because we understand work is going on in these areas, we're not looking to use these dollars to fund new services, either healthcare services or social services. We're really talking about how do we get organizations that are doing this work in different ways into rooms together where they can collaborate more effectively, where they can figure out what are the barriers to doing this work more effectively and try to make progress on some of those things. The spending might therefore go toward a variety of planning activities, coalition building, including selecting a particular structural barrier to health and trying to outline a multi-level plan to try to address it. It might go toward supporting data and IT infrastructure, staffing, communication activities, developing community engagement strategies, all those kinds of things that actually support the execution of some of this work. We're talking about awards in the neighborhood of $600,000 to $700,000, and again, we're looking at making 2 such awards in the first round, and that would be over the course of 3 years. So that's prong 1. Closely related is the technical assistance work stream for MassUp. DPH is at the table with tremendous expertise in how to support these kinds of collaborations and how to think about public health and the healthcare sectors coming together. So they are preparing and ready and able to offer technical assistance to these collaboratives. DPH is also has resources to support an evaluation of the initiative overall. And finally, the aligning policy prong here, not the last but not at all the least important. The state agencies that are around the table for this initiative are really committed to helping identify and try to start to mitigate policy barriers that may be getting in the way of some of these effective collaborations. So there are probably things that state agency representatives will be able to know sort of off the top of our heads when we put together all of our work in these areas and try to start to break down those silos and provide more effective means for the constituents that we work with to do this. And there are undoubtedly things that will bubble up from the investment awardees as they encounter on the ground real challenges of doing this work. And that's what this policy alignment task force will be charged with trying to do. And the first step I think we're going to be taking as a group is to try to bring people together for a learning forum to really explore what are some of the major policy barriers and what are innovative strategies happening on the ground to try to deal with some of them. So on that note, before I wrap up, this is my last slide, and really interested in your initial thoughts and feedback on all of this. But just from a next steps practical perspective, we are convened as an interagency group, and we're working hard right now on preparing for an investment program design and release later this fall. The first steps of that are going to include another few opportunities for stakeholder engagement in a variety of ways. So stay tuned for more information about how to provide input to us both in written form. We will probably do a request for information. We may hold listening sessions. We're always interested in talking with groups about these issues. They are just as complex as some of the ones you were just discussing for the balance of the meeting. And then we'll put out an investment design and a procurement, hopefully, before the end of the calendar year. On the policy alignment side, we are working hard already on this sort of learning forum opportunity in early stages of planning that. But we've got a great group of state agency folks around the table to move that forward. And I'm really looking forward to seeing, where we go after that initial kind of first item on our agenda as we really try to tackle and dive into some of the policy issues that are coming out of the investment work. So that's really a very high-level, quick overview of the initiative. Lots more to come, but thanks for hearing about it and looking forward to any initial comments you might have.
Kathy, you did a great job in the time allowed. That was excellent. All right, I'll just go around this way. Mike?
One quick thought. Given the fortunate state that we're in Massachusetts, that we have not-for-profit entities, both hospital systems and community hospitals and health plans that tend to be predominantly not-for-profit with a public charities mission that's tested in multiple venues. I would think one of the priorities that would be important to include within the structural approach would be incenting value-based ads for for-profit entities that don't necessarily have that same mission and charter to begin with. And I do think that there's a real value to crafting it in such a way that, let's just use national insurers, for example, don't have similar commitments to these projects that Harvard Pilgrim, Tufts, and Blue Cross do because they're not-for-profits with charity missions.
Amy?
So this is really exciting. So Healthcare for All has been working in partnership with MPHA on a Boston Foundation grant that is winding down year one. We'll be very close to being able to share some results, and I don't know how much you know about that, but we've been looking and interviewing ACOs and community-based organizations and the interplay, and I think that there's probably a lot of lessons learned. You're nodding your head, so I think you already know about it, but we would very much welcome the opportunity to make sure that the learnings we have from this first year of a 3-year project could be integrated into what you're thinking about. So thank you. This is really exciting.
Absolutely, and there's, as Catherine said, a lot of tremendous work already going on. The Boston area ACOs have a collaborative that's been spending some time on this. The Blue Cross Blue Shield Foundation has made some mini grants that get at some similar things, and not to just call on those two organizations, but there is, and we don't want to duplicate, and we definitely want to learn, because this is such an emerging area for how to do this well, and that's something that we want to be able to add to the evidence base ultimately at the end of the day.
That's great.
Diane?
Thank you.
Just a question, this is very interesting. Are all hospitals and providers eligible, or are there any exclusions?
We're talking about the investment program being eligible for HPC certified ACOs as the applicant. The locus of that is so that we can use, consistent with our approach of delivering funds to healthcare system actors, where we're using that as the unit. So that's kind of the lens that we're discussing.
Thank you.
Carlene?
Hi. Yay. We're really excited that this is starting, and are really grateful to how much thinking has gone into the planning of this, and of course MPHA, as well as the Alliance for Community Health Integration, ACHI, offers however we can be helpful as you move through this process. One thing that I would want to say in this setting is, I think that one of the challenges you might face is, because the grantees are going to be the ACOs, figuring out how to balance the power of the partnerships that are going to be necessary to be effective on the end, and balance the partnership with community-based organizations that are already in a power imbalance with giant healthcare systems, is going to be a challenge when it is the healthcare systems that are holding the purse strings of the partnership. And having run a giant grantee program when I was at the Department of Public Health that faced similar problems, I think there are ways of writing the procurement that can help to balance that power. I think that there are ways of writing benchmarks that can help balance that power, so that there can be true accountability to community needs and community change that can lead to the equity outcomes that you are talking about here and trying to embed in the ultimate outcome of this MASSUP program. So again, we offer support and help however we can do that as you design this. It's
Yeah,
really
thank you
exciting.
so much. And let me stress that we are really thinking hard about that very thing, that power dynamic thing, and we are a little bit hamstrung in terms of our, the entity that gets the award, but 2 specific things we're already thinking about to try to mitigate that issue. One is we have this concept of a neutral convener or a backbone organization that would actually have to be identified as the steward of those resources. So the applicant is the HPC certified ACO, but there would be no, the money is not held by the HPC certified ACO, who gets to decide exactly where it's spent. There's a neutral or a backbone organization in the picture here that is acting as a facilitator, that is trying to help neutralize some of that power dynamic. So that's one piece. A second piece to think a lot more about, but just having some sense of the governance structure here, we would be really thinking about asking applicants to demonstrate thoroughly that the way that they are going to be governing these community collaboratives reduces that power imbalance to the full extent possible. And we'd love to talk more about, all of that with you, because I think we know, healthcare brings a lot to the table, but community organizations are going to know and are going to have deeper roots and are going to be able to probably effectuate the kinds of structural changes that we're talking about in ways that the healthcare sector may just not be in the right position to try to do if they're going to lead it. So we're on your page in terms of thinking really carefully about that.
So Ron, I'm gonna close this out for the evening. We're a little over time. Evening. Oh my God. We're a little over time. And yeah. Thank you for this great conversation. This is just so helpful, and I really appreciate these meetings. And you're all incredible people with incredible career, jobs that you spend this hour and a half with us. Is just a great commitment to public service in the Commonwealth. So thank you. And and if you have other feedback, you know where to find us.